Dr. Posner, I'd like to thank you so much and ask you actually if you could take a seat over there as our guest commentator. And I'd like to invite Robert Gotkin too, who is also internationally prominent plastic surgeon from New York. So we're fortunate to have two of the most prominent plastic surgeons in the country to comment. And what we're going to have now is a live demonstration from Susan Weinkle, who has many, many accolades. Currently, she's president of the American Society of Dermatologic Surgery. She is one of the best teachers of fillers in the country. She just has a special talent. So Dr. Weinkle, we're honored to have you here, and we have some expert commentators that maybe could ask some questions or make some comments for you. Would you like a mic? You need a mic, and we'll get you a mic.
We're flexible, we're flexible. Okay, now, let me show you what I do. Sometimes in the office, when you want to stay clean, you just grab the inside of that glove wrapper. There she goes. So we have to be creative when we need things. Let me just ask, how many of you have injected hands? Okay, good. I personally don't find patients come into my office saying, I'm so excited about having my hand injected. They haven't read it as much in a magazine. They don't really know about it as much. So this is something I think where we have to lead the patient to understanding what we can do for them. And so I also like to tell patients, you know, once we've done all these wonderful things to your face and you put your hand out there, it's a dead giveaway of where we're coming from unless we work on the hand. And I think is hopefully if we see this economy turn around, people have a little more discretionary income after these baby boomers have treated their face, they're going to be more interested in the hand. Now I tried Sculptra in the beginning for a hand, and I am still 3 years later sporting my own Sculptra nodules, so I don't do that anymore. And our patient here, I've explained today that we're going to inject Radius, which is now my favorite filler for this location. I think it has a wonderful softness, one that's mixed. Oh, okay. Want to put it in that pocket over there? Put it right on my coat. Yeah, you button it. Oh, he's buttoning me. Okay. All right, here I can hand that off. Okay, excellent. Now, you still hear me? Good? Okay. So anyway, after having tried a variety of products in this location, I've come around to thinking that Radius is my best choice. I think it has reasonable durability. It's nice when you see a patient like this. If we can see our hands a little close up on that. Okay, perfect. We don't see a lot of discoloration. We don't see a lot of lentigines. We just see the beginning of this skeletonization and the loss of volume that she has. Now, when we started putting Radius here, we used to do the matzo ball technique, and we put a big blob of it, right, gentlemen, and we smushed it around. And in my patients on Coumadin and blood thinners, the smushing was worse than anything, and they ended up bruised to heck and gone just from trying to smush the stuff around. We know there's a lot of vessels here, and so that's why I find that the cannula is particularly valuable in this location. So what I'm doing is taking this is a half cc. I needed 1 cc, please, Am. I need a whole cc.
So Susan, your typical dilution now is 1.5 of Radius to 1 cc of lidocaine?
Yes, I heard you say you do 1 to 1?
Somewhere between 1 to 1, depends how I feel that day.
Yeah, and I will tell you that I use lidocaine plain. How about you?
You know what, I go back and forth. Most of the time plain, but I think some people say there's a role for epinephrine in there to decrease some bleeding. But I don't really notice any bruising or bleeding with the cannulas anyway, so I'm not sure it matters.
Have you ever injected yourself,
yes.
Jason,
with
a little lidocaine with epinephrine?
Only when I've done intraoral blocks on myself, I really have felt the epinephrine. Really, if I've just done other areas, I haven't felt it too much.
The epinephrine burns.
Yes, the epinephrine burns, but you can also use lidocaine with epinephrine that's been buffered.
Right.
Like we normally use for local anesthesia.
Exactly.
Use the buffered. I tend to use lidocaine with epinephrine with the calcium hydroxylate.
Even with a cannula?
Yes.
Okay, I find that the plain does me just fine, because with the cannula, you're going around the vessels and not hopefully through them. So what you can see I'm doing, I wait, my assistant sets this up for me just like this. I walk into the room, I do my own little swish back and forth, and the nice thing is you're not going to hurt this product. You can beat it up back and forth, and you're just fine. All right, and then what I'm going to do is I'm going to ask my assistant to please hand me a gauze and a 21 gauge needle. And if you will then put the, you see you can't put it all back in there, so you've got part of it left here. A 21 gauge needle, it's just a regular draw. There's one over here if you can't find it. Okay, and a gauze, please. All right, and then if you'll put my 25 gauge 1.5 inch cannula on there. I want the 21 inch needle for my little dagger, tiny dagger. Okay, and what I tell the patient, she's had some topical anesthesia on here, mainly because the only thing she's really going to feel is the prick with this 21 gauge needle. What are you using to do your little incision with?
Same, 21 gauge.
And most of the time I'm still using the soft fills, which come with a needle, so I use the enclosed needle.
Okay, so I'm going to make a little...
Which company is this, Susan?
Excuse me?
Which company cannulas are these?
I'm going to use the DermaSmooth.
Dermasculpt.
DermaSculpt, I'm sorry, yes, DermaSculpt.
What size is it?
A 25 gauge.
Okay, and the length?
And isn't it funny, sometimes when you stick the skin, it doesn't bleed? Yeah. And you think, well, I just stuck you. You should bleed already. So you got to see the hole here. And getting the hole and seeing her bleed, that's the part of the deal here, is getting it in. I kind of go the direction I'm going to go. Okay, if you could just hold this for me, because I'm going to use this again.
How many holes are you making?
How many holes am I making? I'm hopefully making one hole.
You're going in one space on each hand?
Well, I'm just going to start here. Now, this is the trick right there. Oh, that was just beautiful. It's my lucky day. Some days it doesn't go in quite so easily. And then what I'm going to do is just gently, how you doing? Great. You can't see from out there probably, but my patient is just smiling like a Cheshire cat. I've seen not a single wince. And I'm just fanning from this one position because, look at, here's the tip. That is a 1.5 inch 25 gauge cannula, which flows so easily across the hand. And sometimes I arch it just a little bit to pop around there, and it just literally pushes the vessels away. I mean, actually, this is like taking candy from a baby. I could almost do this as fast as Jason over there. I don't know, that was a lot of syringes in the face at once. Any comments, guys? What do you think?
Well, I think that one of the advantages of the smooth, of the blunt cannulas is that you can go around and above and below the vessels, and you don't have to make multiple incisions, which we often did previously. If we didn't use Susan's so-called matzo ball technique, a lot of people inject in multiple intermetatarsal spaces, and now with the blunt cannulas, you can avoid doing that. So that's an advantage of the blunt cannulas.
Don't you think it's amazing when you stick the skin and you can't see the hole? It doesn't bleed?
I'm not going to comment.
I mean, have you ever had that happen?
All the time.
All the time. That's the most aggravating part about the whole thing. I love the cannulas. It's seeing the hole that's the little tricky part.
You know, at this point, I won't even do a hand without a cannula.
No, me either. I'm only doing strictly a cannula.
And temples also for me. The other areas I'll go back and forth, but hands and temples, because there's so many veins just sitting under there waiting for you to hit.
I think that it's interesting you do the temples more superficially. I actually go down and feel the periosteum and then fan just above in the submuscular plane.
I think, you know, either way works.
Now see, sometimes you have to put your finger down on the shaft. There we go. This actually is a really easy area compared to some areas of getting that cannula through the tissue, because this is just such a loose area. And then you can, she says, I know she hates those veins. I'm going to make sure I track right along a couple of those veins. Okay. I think this is really a match made in heaven for the right product, the right way to deliver it, atraumatically.
Susan, is this now your favored product for hands?
Totally, totally.
Do you use HAs at all anymore for hands?
I really don't. I did when I was sort of learning this technique in this plane like this, but I just find that it is so wonderfully, it's just so smooth and it's good volume, a little stiffer, higher G prime than our HAs, and I think that it's got good durability. I find that if I put in, now that was 1.5, in my 86-year-old mother, I once put 3 cc's in her hand and it was great. She didn't have a bruise, not a bruise. Okay, any questions? You're welcome to comment. Any other? I just think it's like, I've had it in my hands, I love it. And that's how I decided not to go with epinephrine. Because I did one hand xylocaine plain and one hand xylocaine with epinephrine, and epinephrine hurt like a booger.
That's actually a good little study.
Yes, that's my study of one. But, you know, it's a personal field, so you could tell it really, the epinephrine made it hurt more rather than making the injection product hurt less.
I mean,
Okay.
This is so simple. I mean, that's the thing. It's so simple. It's really no
Yeah.
questions. You look at it and go, oh, okay, why weren't we doing this 5 years ago?
It's like the temples. Why weren't we doing that 5 years ago? Okay, so how was that?
Right.
She said it was great. Now that's a good thing. That patient doesn't dread coming back. Yes, ma'am. Very good question. Let me repeat that. Have we ever had subsequent swelling 2 or 3 weeks later? I actually haven't had it 2 or 3 weeks later, but I've had it 2 or 3 days later. And I have no good reason for this, but I treat them with Cipro and it goes away. I can't understand the mechanism of action because sometimes it'll just be one hand that's swollen. Now I do prep my hands with Technicare. And I don't know why that is. In myself, I had the same thing. One hand was swollen a little bit and tender. I elevated, I did everything the same, and I took some Cipro, and within a couple days, it was fine. So that's my plan. Now what I do is I send the patient home with a prescription, assuming they're not allergic, with some Cipro, and I say, if you start to develop any tenderness in one hand or the other, take this for 5 or 6 days, and it seems to subside. What do you guys think?
What was the hand of yours that swelled, the plain or the with epi
I don't
hand?
remember. Sorry. But do you ever have that happen?
You know, I had one patient with persistent swelling, and it actually came down to some hair dye. That was the problem, but I haven't really seen
Hair dye?
Hair dye.
I would never admit to that.
That
Hair
was it.
dye.
It wasn't me. You know.
So I think that the Cipro is a good idea, although I tell you I don't have an exact reason why it works. Maybe it's anti-chemotactic, I don't know. But it has helped in the couple of patients I've had that situation. You had a second question? Okay, the question was, is there a limit on the amount you want to put in at the first treatment? I think it's variable. As I say, this was 1.5. We could probably put even another half a syringe. I try to look at someone's hands, and she comes into my office, she's got to have a budget, right? She needs to have some idea. I would look at her and tell her probably 3 1.5 cc syringes. Again, I have ancient patients in Bradenton, and sometimes I will put 3 cc's in one hand at one time, and without any problem. Yeah, you know, I just feather it back, and sometimes I actually even use the 2-inch cannula. So if someone's really atrophic and I have to reach really a far distance, I would use a 2-inch cannula.
But just note that when you go up in cannula length, you often have to go up in the diameter.
Right, that's a very good point. If you go up in cannula length, like for instance, this was a 25 gauge, whereas normally, you know, with a needle, a 3/4 inch needle, we use that 28 gauge needle, that hollow bore needle. But as you get longer, it's harder to push.
And they move.
They are flexible. So, you know, it's a yin-yang. I mean, you get something for distance, but it does become a little more difficult to control a slightly longer cannula. 1.5 seems to work nicely in my hands for that. Okay.
One of the problems that I found with the 28 gauge cannula is that it's too flexible. So it's nice that it's small, but it's too flexible, and I think the 25 gauge cannulas, or if you're going longer, and even larger gauge cannula is much better.
interest of time, or do the other hand? Okay, I'll do the other patient. I don't know how much time we have. I'm trying to stay within our limit. Should I do the other hand now? 2 hands, okay. Okay, we'll do another hand. We're grooving on these hands. Okay.
And the other thing is, don't be afraid to use the larger diameter
Oh,
cannulas.
show the 2 hands, I'm sorry. Put them side by side. Okay. Look at them side by side. Now, she does have a little bit of a bruise. Oh, here, they're coming. A little bit of a bruise right here from where I was jabbing around with the needle, and maybe a little bit right there. But look at that. I mean, that is, look at the difference here. Look at the volume there. How long does it last is a question. Again, variable according to quantity that you put in. If you kind of undertreat, you're probably not going to last as long. Oh, sorry. I was holding your hand. If you put in 3 cc's, like I did my mother a year ago, and her hands still look pretty good. And mine too. Mine are not so bad. So I think that how long, just like with a lot of the fillers that we are doing, it is volume dependent. You know, if you kind of undertreat, you're probably not going to get as, and so you need to give this patient some idea. You need to tell her how much it's going to cost in terms of how much product you think you're going to need to help her, and also how long she might anticipate. Now I don't know if you guys have this, I have 1 or 2 patients in my practice that just eat it up.
Especially the workout people.
Yeah, they're just fast metabolizers. I mean, somebody who's really like, you know, working and doing stuff, those real skinny athletic people, they just metabolize everything. And so you got to be realistic, because you don't want them mad at you that you said it was going to last a year and they're back in 6 months and it's gone. I always make sure that I, you know, explain to people quite carefully the duration of the products is variable from patient to patient.
Susan, I'm going to ask you a question.
Yes, go right at it.
Assuming that budget is not a factor,
yes.
Would you treat to correction in 1 session, or would you do multiple sessions?
That's a very good question. I think, Robert, if it is a patient I've never treated before, and she comes in for her hands to be treated, never ever touched her before, I'd probably undertreat. I'd go on the low side and say, come back and we can do a little touch-up. If it's someone of my junkie patients who get treated on a regular basis and are very comfortable with my skill and what we do, I'd probably treat to correction. What about you guys?
It goes back and forth. A lot of times I think that you're going to get a lot more swelling when you put multiple syringes in the patient at the one time. So many times I'll tell the patient, well, let's do 1 or 2 syringes, see how you do, come back in a month and we'll retreat you. Right. If you need it. And also there's that budget factor, because you know let's say they're paying by Amex and they see that Amex bill. It's nice to spread that over 2 months rather than put it over every month. Because people freak out. They look at their bill, they said, oh, I spent $4,000 on fillers on something that's going to go away in 6 months to a year, and a lot of people are more comfortable spreading it out over time. So that's like a real practice issue.
I think that's exactly right. And I think that I have a lot of my patients that pay part of it with a credit card and part in cash.
They're hiding it from their husbands.
Because they don't want the husband to know.
That's the husband hiding technique. Right.
How come we both know that?
Yes, you know that. Well, you know, we have to practice that in a variety of things. It's not only fillers.
I think my wife's shoe collection is something along those lines.
Yes.
So does your shoe collection, I'm sure, as well.
I could be guilty of that as well. But see, now look how nicely that flows in there. Because it's mixed with 1 cc of lidocaine plain. It goes in there very, very easily. I probably start from right to left because I'm Jewish, right? I don't know. It's all in how you do it. Doesn't really matter. Just that you do it very gently. And I like talk aesthesia. I like always talking to my patient, looking up, making sure the patient's still with me. One time I was injecting at a meeting, I looked up and the patient had an nystagmus. She was about to faint. So you always got to touch base and see that.
Susan, let's talk a little bit about the topical on this, because you know, I put topical on my patients. I don't think it does anything, you know, for hands, because you're doing one little poke hole. I actually would prefer ice. I think I put topical on just to waste some time so I can catch up in the office before I see those patients.
My exact reason for using the topical a lot of times, but sometimes you can put the topical, because listen, you do a lot of this. Topical stuff gets expensive, you know, I'm very cost conscious. So I just put a little topical right here in the web space where I'm gonna make the incision. You don't need topical up in here. No,
you don't.
Okay.
You don't need topical on the part of the hand where you're implanting the product, because it really doesn't hurt going in. You've diluted it with, or mixed it with lidocaine. And even in the days before we were mixing it with lidocaine, the radiesse really does not hurt going in.
And also the product, if we can get away from the hands, I know we're going to the cheeks next. On a cheek that has not had a lot of previous injections, it doesn't hurt that. These blunt cannulas don't hurt that much. Patient who's had extensive, especially sculptura or a previous facelift, it's a little bit more fibrous from scar tissue, so it may hurt a little bit more in those patients. But the hands are pretty loose areolar plane, and really, usually nothing except some of these fillers has gone in that areolar plane between the tendons and the vessels.
The other thing is, while I'm treating this hand, I noticed she does have on close inspection a few lentigines. So as a dermatologist, we would know we would be doing her a terrible disservice if we didn't also treat those lentigines. Now in my office, since again, I am not high tech like these guys over here, I don't have any lasers, I sometimes still will lightly freeze those with liquid nitrogen and then give her a prescription, which I sell in my office, of some hydroquinone. And then I can help improve that skin. I also encourage my patients to use a retinoic acid on the skin, because I think I could take a bath in retinoic acid, actually. So I encourage them to use a little bleaching, kind of a triluma affair with a little hydroquinone and a little retinoic acid. And if I think they're going to get irritated, they have real thin skin, fine skin, I would give them a little mild cortisone. But improving those, you might not see these on the camera. She has some like little very fair lentigines here.
Susan, you need some technology in your office.
I know.
Okay. I mean, this is so easy. I mean, if there's some brown spots on the hands, you know, pulse light works really well.
Listen, liquid nitrogen does a great job.
Oh, pulse light is so cool. You get reds and you get browns, and then for textural things, you do little fractional lasers, easy stuff, right? You agree?
Exactly.
Listen, that Q-tip I learned at Stanford University in 1980, it's still, I can dab right on those little suckers, peel them off, a little hydroquinone. Very, very economical. Or a little TCA. Little TCA is lovely. You can achieve a lot with a little.
We like our toys.
Okay, all right, so there we go. That's 2 hands injected. And I didn't hurt you, did I?
Not at all.
Not at all on the hurt level. That's good. Okay, excellent. Very good. Okay, now for my next patient. Okay, so it don't fall in the cracks.
Look into the camera, please. Look into the camera.
Okay. Now, I do think it's really, really important to find out what bothers the patient. Because if you just treat what your eye sees, I don't care how great you did, it's not a home run. So the first thing I do when I talk with a patient like this, in my office in consultation, new patient, is have them hold the mirror and let's decide what bothers you and what you've had done elsewhere. I need to know your card to know what all your dance cards had on it, so I can know, you know, what to expect in terms of, sometimes people still have had soft form. We used to put that, I never did it. Did you ever put that PVC pipe in people that, you know, sometimes you got to know what you're working around. So you want to get a good history. What is problems has she had? Has she ever had any fillers? And what bothers her? And in this case, the patient said, whatever you see. So then you know you're good. You've got a whole palette. And what really struck me the most when we chatted was the fact that she does have a little loss in her tear trough. She has a nice cheekbone. She's got a nice definition of her mandible. Some fine wrinkling here, which I would generally address with some Sculptra. Do you look at this right here, Jason? Look at that. Can you see these little fine accordion
or fractional
lines?
CO2.
Laser.
Oh, CO2, okay.
Erbium, either one.
So you would laser this?
Yes.
Emergency.
Okay.
Okay, and if I saw her, she'd be in the office getting coordinated for a laser right away. She's
Right
a
away,
she's a
emergency
perfect-
laser treatment.
She's a perfect laser candidate. Perfect.
Okay. I, of course, am going to see that she's got some loss of volume. She's got some real preauricular loss here, and so I would treat her with some Sculptra. I would also, again, improve those little tiny lentigines and lighten all that, and all of those treatments are going to improve her before I've even really done much in terms of looking at specific filler. This is kind of the roadmap and the way I evaluate. Look at this. If you put your hands on that patient, she is screaming at you where her volume loss is. She really is a classic example of how that jaw has rotated, and she's quite sunken here due to the architectural bony loss. And then, when we come up here, we can say, if we revolumize this with a high G' product, like calcium hydroxylapatite, sometimes I can then come even into the angle of the mouth and layer a little soft product like Juvederm to help give her a little structural support there. So we're going to start here in the, I often start from the bottom and work up. Let's see, where are we? We'll get my little gloves. I need a small. Okay. Please, Sam. Okay. And then I'm going to take radius again, only this time I'm only going to take it, now they drew up a CC, but I only need a half. We'll waste a little there. Here I like the product to be a little
Susan, before you inject her, can you have her tilt back a little bit so you can see the cheekbones?
Okay.
Both ways. So one of the tricks is go behind the patient, look from the top down, and also look from the, see if you can get her from the bottom up just to see the evenness of the cheekbones, because they will certainly notice asymmetries afterwards, so you really need to point them out beforehand.
I think she's quite even, don't you?
No, the right side is...
She has fairly significant malar asymmetry. The right side seems higher than the left.
You can see it here?
Oh, look on the screen.
Oh yeah, because I can't get around that way. Interesting, because you can't see it from here. You can only see it head on.
You have to do it from what we call the worm's eye view. You put the so that when you look at her, the tip of the nose is between the eyebrows.
Well, it's hard for the tip of the nose to be anywhere else but there, right?
But that's the level that you're looking at. You're seeing the tip of the nose right in there.
Okay.
And then you're looking at the projection of the maxillary zygomatic complex.
And when I'm injecting somebody, it's very hard to do when you're on stage, but I like to walk around, so I'll look at them from various angles, especially from the top down is a great view. You can really see the highlights of the maxilla.
That's a very good pearl. Jason, that's excellent. I didn't know to do that. But I do walk around. I do think you need to look at it from all different views, especially I tend to be right-handed, so I do a lot of my injecting from the right side of the table, but I think that I frequently do walk to the end of the table even and have the patient sit totally upright, because when you're leaning back some, I mean, we all look better leaning back, so I have them sit totally upright, and I come to the end of the table to see if I look like I'm in a good, and then I have the patient, when I've injected part of it, take the mirror and look, because you keep them informed about what you're doing as you go along there. Okay.
And one of the tricks is that you're going to start seeing a lot of 3D photography over the next couple of years. One of the companies that we work with is Canfield. They make the Vectra system. I don't know if they're here, but I would love it if I took every patient and did a 3D analysis of the patient, because actually with the picture you can then show the patient from different angles what they look like, and you can really point out these asymmetries to the patients preoperatively. Because I can tell you, if you don't, they will show you them later on. They'll look at the cheeks and go, wow, my left cheek is so much bigger than the right cheek. And then really, if you haven't really gotten good photography of the patient, you're going to be the one touching them up for free.
Now here we're using alcohol to prep with. Again, when I'm using these durable fillers, I frequently will use Technicare. Of course, I'm running out of it. I had a big stash, but I don't know, I have to go back to Hibiclens. What do you think? What are you using?
Just
what do you guys use?
Injectables, alcohol. But
just alcohol?
In the operating room, we have a whole bunch of different things. The key is to get the makeup off. And the patients always tell you, oh, I took my makeup off already. And then you start wiping them with alcohol and the whole wipe is brown. Okay. So you really need to get that off the patients. Otherwise, one, you can micro-tattoo them, and two, you can get some bacteria into the skin.
Now, a little ouch. Now, when I'm doing the marionette area, I like to go from medial to lateral. This is the worst little stick right there. Okay. Good. Little ouch. Always kind of talk to the patient. I think that talk aesthesia is really important to let them know what you're doing. Can you hold that for me? Okay, now I'm using a MERS cannula that is a shorter 1-inch cannula, because with the push-ahead technique, I can get right to where I want to go. Making sure I don't step a hole here. Okay. The other thing is, thank goodness I have electric tables in every exam room. Little ouch. These are a little bit harder to get in.
So Susan, I'm going to give you something to comment on.
Yes.
You said that you like to start from the bottom and work up.
Yeah.
And I'm going to tell you that I like to start at the top and work down, because I feel that if you volumize the upper face, you do get a little lift in the mid and lower face.
True, I agree completely. I don't argue with that one bit, I'm in complete. But in this case, I wasn't doing really a total facial volumization. I really had specific areas I was going to pinpoint. And the reason I like to do that is that I begin to see a softening here. I was only going to layer a little Juvederm here and just do a little Restylane here. So I wasn't doing a real, but I think you're exactly right, especially when I'm doing posterior revolumization. I would always start in that direction first. Now see how easily that, how are you? You okay?
Susan, I want to comment on what you're doing. You can tell that Susan is a very experienced injector. Watch the white stuff. Watch how slowly she injects. Okay, a little bit at a time, no lumps. Don't do squirt and get rid of your whole, injectable in one sitting and then massage it around. She's putting a little at a time. She's changing direction. She's not afraid to push here and there with the blunt cannula because she's not going to get any bleeding. And you can see how smooth, how nice it's coming out already. It's beautiful. And what she's doing with her other hand is very important. She's tenting the tissues.
Yes, this is my brain finger right there. But you also notice, could you have the camera come down just a little lower on my hand? A little lower on my right hand here. I want to show my hand how I hold the syringe. See this right here? I have had to learn to palm it because my thumb joint, after all these years of injecting, is so painful. So if I go like this as opposed to like this, then it takes a lot of the pain off my thumb joint.
I sense a disability claim coming.
What was that? Because I'm an old broad.
I said a disability claim.
Okay, now, could I have a larger gauze, please? I feel like I'm in the skimpy ages. Now, this does get a lot of edema, even with the cannula, I find. It's very hydrophilic, the product. It's also very nice and malleable.
Did you change your dilution?
Excuse me?
What was your dilution of the radius?
I did 0.05. I just did a little bit, so it's fairly concentrated.
So the beauty of this product is that we're able to change the rheology by varying the amounts of lidocaine that we're putting into it. So you remember, you're changing the rheology, you're changing the G prime, and you're changing, obviously, the amount of fill that you're getting in that particular area. So an area like the temples or the hands, you might use more lidocaine to dilute it a little bit more, and in the cheeks or this area where you're looking for a little bit more fullness, you're going to have a slightly more concentrated product.
Now, what I'm going to show you is the next thing I like to do, which is kind of the layering. I just give that a good mold. Now, do you have any problem with bimanual molding? Do you think your problems with infection? What do you think?
If I'm putting my finger in their mouth and molding it, I will change my gloves.
Yeah, you change your gloves. If you stick your finger in someone's mouth to mold,
change your gloves.
gloves.
Don't take that glove and mush it around their face. And I think most of us have stopped doing intraoral injections at this point. I was never a fan of them. Intraoral injections for these fillers, because you're going to get some biofilm on your fillers if you're injecting them through the mouth.
And see, even though I did a nice, smooth, even injection, I like to come back and I really think of it as being a sculptor. It's very rewarding at the end of the day doing these procedures. And I'm still a Mohs surgeon in the morning, and I'm a molder sculptor in the afternoon, and it's really quite nice. Now, I'm going to take a little Juvederm Ultra on a 30-gauge needle. I like to bend that needle at a little bit of an angle. And then I'm going to come right up to here. Now, I'm going to open you just a little bit now. Little tiny ouch. And I'm going to come right up here and give her this little strut. See right there? Just a little extra support with a little HA, which the nice thing is these are all so wonderfully biocompatible. Now she does not have that puffiness on the upper lip from her hypertrophy DAO, so what I'm going to do also then sometimes is come and just put a speck, little ouch, always look at this hand, little counter traction there pulling back. And I can tell you that being a surgeon and having been trained at the hands of Dr. Robbins at times to know that how you use your hands and counter traction with tissue makes a huge difference. I also want to tell you that you see these little etch lines right here that you guys are going to laser? Well, we poor folk that don't have a laser, when I get Belotero, I'm going to layer Belotero into those little etch lines.
Good choice. Good choice.
We've been waiting for a year and a half because a lot of us went to go inject this product overseas they thought it was coming out quickly. So we've been telling our patients, Belotero is great for all these lines. So I have a whole bunch of patients who have been waiting for this product. It's a thin HA that doesn't give you the Tyndall effect.
Yeah, I think that's what we're going to really enjoy, having Belotero, and we should have it soon, so it's coming. Okay, so that gives us a nice...
Now, when you finish this area, just have the camera go out a little bit, because I think everyone should appreciate what a wonderful job you did on this side of her chin and her face, because there's a tremendous difference between the two sides that you can see now.
I used about let me look at that, about 0.9. Now that's a really good point, because this patient said to me, I can only afford one, you know, we got economic times. I can afford one syringe radius, one Juvederm, one Restylane. So you do have to keep your eye on it. Here I know I've got a little more freedom with that, so I would maybe watch and only put half of it here and half of it here to make sure I was fair with that. Now sometimes I will take a 31 gauge needle and try to efface that little etch. Oh, you can't see it very well, but there's a little etched line right here. And even if I take it like this and a little ouch and just thread that little line some with this very nice soft Juvederm. That's why, and I don't find that the Tyndall effect is quite as great with Juvederm as it is with Restylane. Now, face down. Now, that being said, let's save that, and I'll take the Restylane, please. What I'm going to do next, I'm going to treat this one whole side of the face first. I'm going to come up here and show you how I do the tear trough. And I know we have, sometimes in this tear trough, I will use a cannula. Sometimes I will just make sure I am the submuscular, supraperiosteal plane, so I'm a little more avascular if I'm not going to use a cannula there. Okay. This needle right here. Okay. This is the Teruma needle actually that comes with. But when you go back to these short half-inch needles, you feel like your finger's cut off. Another choice here is a 27 gauge 1¼ inch needle so that you make fewer percutaneous sticks. But I want to demonstrate kind of the push ahead technique if you're sticking with this little Teruma needle. Okay, now you'll feel just, I'm going to see right where it comes down here. And I always try to keep the needles down out of the patient's view. A lot of patients are really needle phobic. And the more pleasant you can make your experience and the less traumatic for the patient, the more they won't dread coming back to see you. Okay, here we go now. We're going to take just a little ouch right there, and I'm all the way down. I touch the periosteum, and then I'm going to go very slowly, submuscularly, going forward. There we go. Good. Very good. And then I'm going to come out. I'm just going to gently mold. Now, this is Restylane. What is your choice in this area?
Juvederm.
Restylane.
Restylane?
But diluted. I'll dilute my
But probably Belotero when it comes on the market.
Okay, now again.
This is one of the most difficult areas to treat.
Little ouch, ouch, ouch. There we go. Very gentle.
One trick, Susan, I picked up from Michael Kane, a good friend of all of ours, is I'll take the Resty and I'll dilute it a little bit for many of the areas and inject it with a 32 gauge needle.
Oh, really?
So I like the 32 gauge Botox needle in the tear trough, but just very slowly. You can easily cannulate a vessel with that.
Yeah,
Go
I was
slowly,
very
little at a
slow.
time.
I think slower injections make for less traumatic injection.
Absolutely.
Don't squirt, just nice and slow pressure.
Yeah, and then what I do is I come back and I know that I'm an hour behind and there's nowhere to sit out in my reception area, but I'm not going to rush. And I don't want the patient to think I'm rushing. I think that's really part of the art of it. And then I take time and hold a little pressure because this is a very, very vascular area. All right. And the reason I like Restylane here is because I think Restylane it's a little stiffer, has a little higher G prime and stays where I want it. It's not quite as soft and malleable as the Juvederm that I put down here. Okay, how you doing? Good? Now, she's still going to look at herself, and you may not see this, but she still has a little discoloration. Her volume has been replaced, but the skin is still a little bit discolored. I think it's one of the hardest things we try to treat. What do you do for that?
For which?
For the discoloration of her skin.
Oh yeah, it's very difficult, and a lot of the lasers, even though we like them, they're tough in this area.
See, there's a little trick sometimes. The first thing I do if someone has discoloration in the lower eyelids is I will pull their eyelid skin down. And many times you'll see a lot of small little vessels in the lower eyelids. If that's the case, sometimes they will clear up if you use a vascular laser along the eyelid. So you have to be very careful. Obviously, eye shields, or at least you're treating over bone. But just pull down, look for vessels, and you'll find if you kill those vessels with any of the vascular lasers, many times the eyelids will lighten up. So that's my first line of attack. After that, I usually resurface them.
Did you see that I treated laterally as well? Sometimes there's a little post-orbital fat pad that you want to camouflage here, but sometimes there's also a little sunken loss of volume in the periorbital region. So what I did was very carefully injected away from the globe in this area, not toward the globe, because if the patient was to move, then you might have a problem. And so what I do is go away from the globe and then just very, very, very gently massage that and mold that into that area. And so that makes for a nice periorbital, and that was about 0.3 cc's, so not very much. So I could easily tell her, looking at her pre-treatment, that about 1 syringe of Restylane, 1 syringe of Radius, a little Juvederm for icing on the cake, and that's going to make her feel better tomorrow morning.
Okay, but this session is supposed to be about cannulas. So when do you use cannulas in the tear trough? Ever?
I do use cannulas in the tear trough. I sometimes find that I have a little bit more bruising trying to get the cannula in there. What do you think?
I still use sharp needles around that area, but I should be using cannulas. So
I mean, I have used the cannulas. I had one patient, all you need is one problem, right, to get you a little scared. I had one patient who bruised so much from where I was trying to get the cannula in. I traumatized the tissue. What I've really gotten to the point of liking in this area is the 1 1/4 inch 27 gauge needle. So I can start from even way down here laterally and make one injection point and do the whole entire tear trough.
You know, it's back to that minefield issue again. There's a million vessels all over the place there. So probably when you're using your longer needle, you're below the orbicularis muscle. So if you're anywhere near the orbicularis muscle, there's a lot of little vessels that get into the orbicularis muscle. That's what you're hitting. But I can tell you that whether I use a sharp needle or a cannula, you do get a lot of bruising in the periocular area. It's just common.
It's really tough. I don't think that the verdict is out yet for knowing exactly the best approach. I do think that this short needle is certainly trickier unless you do the push ahead technique with it. Right now, I tend to be leaning toward a 27 gauge 1 1/4 inch needle.
Susan, well, keep going, but I have a quick announcement for the audience. Dinner is about to be served, and for those of you sitting in chairs at the back, you won't get dinner because you're not at a table. So you need to move to a table. So for people who are not at a table, come forward. There are plenty of open chairs up front. Put yourself at a table.
It's okay.
You guys keep going, and dinner will be served in a few minutes, and then we'll be moving on to Dr. Sundaram and continuing with our fillers and injectables, but keep going.
You know, one of the other things is the use of ice. I like to have a cold pack of ice with the patients at all times. So especially in the periocular area, the use of ice, I think, will shrink some of the vessels down. So I really think you get less bruising because you get a vasoconstriction from the ice.
Save that. Okay. I'm going to mix up another one so we don't have to change out. Okay. I like ice too. That's my one marketing piece I do. I have my little logo on my ice pack. And I hear they show up in a lot of lunch boxes at school.
You're starting young. It's like the crack dealer.
Well, we do have a few people that young. I don't want my head to be in the way. This is the hard part right there. Don't you think it's amazingly, sometimes it's just hard to pop through? And once you pop through, then you're home free.
You know, but think of it from an anatomic reason, okay? Your area, where you are now, there's a lot of muscles, and that skin is firmly attached to the underlying muscle structure without a lot of fat. So there's a lot of fibrous attachments there. If you're lateral to that area, just sort of the jowl to the cheek area, there's really no attachments. You're dealing with skin on top of fatty tissue on top of SMAS. So there's a nice areolar plane in there that you can generally pop through, but this area is tough because it's supposed to be tough. It's really firmly attached.
It is. You have to have patience with it. It's not a match made in heaven immediately, getting that cannula in. But you can see that once you're in there, now this side has already started to swell. So you don't want to, you got to remember that this has already started to swell some. I can feel it because it's a little warm and the product is so hydrophilic.
So that's why we also, those little ice packs that say Susan Weinkle on them,
Yes.
we like to give them to them to put it on right after their procedure to take them home, so to reduce some of the swelling.
Okay. Retrograde and antigrade? Yes, exactly. I'm putting a little antigrade as I'm going. And the nice thing is you can really do that fanning back and forth very, very, very atraumatically. So you can say, stand back and look and say, okay, let's see, I need to reach a little further over here. And I often would have shown the patient after one side was injected, before I inject the other side. It's very inspiring.
Because you get the wow effect. You have to put a mirror in front of them, and if they don't say wow, I'm upset.
I love, oh my God.
That's good.
Oh my God. Okay. All right. Now, except for that first little poke, when we had to get this in, then it really doesn't hurt much at all. Now, even when this patient leaves the office and she's not bruised, I actually still do give them some arnica orally. And if they've done 3 syringes in my office, I give them the arnica. If it's 1 syringe, I maybe let them buy it. And I tell them, keep this ice on, take the arnica. You may be bruised in the morning, even though they're not bruised tonight. Because that product is hydrophilic, I think it stretches the blood vessel wall and you get a little diapedesis, and then you do get some bruising, even though they're not bruised at all right now.
There's also a big difference in the bruising when you're injecting superficially versus when you're volumizing deeply. You see the bruising much more commonly when you're doing more superficial injections. When you're doing deep volumization, if there's a little bleeding submuscular, you're not going to see it in the skin anyhow.
Good. And then when I'm jibber-jabbing along with my patients, I say, now listen, I can't play the piano and I sure can't sing, but I have very steady hands. And for you, that's really good. Okay, a little bit along here just for some support at the angle of the mouth. And that's why I think we really need to convince our companies to supply us with a needle and a cannula, because a cannula can't do everything. I can't treat this modiolus as well with a cannula as I can with this needle right here. And I can't efface little superficial lines with a cannula.
Right, well that's because, as Jason pointed out before, the adherence in that area.
Okay. Yes, but even like if you were treating a glabellar fold right here, you couldn't do that with a cannula, I don't think. Do you? Do you treat the glabella, do you efface the glabellar folds right here with a, let's see, could you come up a little bit, please? Scan up a little, Kevin. Come down.
The glabella is actually probably one of the better areas to do that.
Do you treat this area right here, these little, can you efface those with a cannula?
But you remember, you're trying to get intradermal, so you really can't get intradermal with the cannula.
Exactly, you can't get intradermal with that.
Susan.
This is some Juvederm, and my grandmother said waste not, want not. So if you want, I'll just put, are you okay?
Okay, I think we're going to be moving on to the next session. So any parting remarks, Susan?
Well, I hope everybody got a little pearl, and it was a pleasure.
Any last questions?
Here.
Any burning desires? No? Going once, going twice.
Okay, lounge.
Okay, we're wrapped up. Thank you all very much.
That was spectacular. Thank you, and judges and panels and brave patients.